Hello everyone. I am Dr. Manab Gogoi, consulting physician, Central Hospital Margherita. Today I would like to highlight some recent advances in hypertension briefly. So let's start. As per WHO report, nearly 63% of total deaths in India are due to some non-communicable diseases, of which 27% are attributed to cardiovascular death, which affects 45% of people in the age group between 40 to 69 age groups. Raised blood pressure is among the most important risk factors for cardiovascular death. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So in our India, the prevalence has gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. This is told by who? Despite that, nearly half of the people of 50 to 51% of men and 41% of women with hypertension were unaware of their conditions. Additionally, over 62% of men and more than 53% of women living with hypertension didn't get treatment. So International Society of Hypertension, that is ISH, has released global hypertension practice guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Heart Association or American College of Cardiology, they have released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risks, that is atherosclerotic cardiovascular disease risk. Among low-risk adults, no ASCVD or 10-year cardiovascular death risk less than 20%, with stage 1 hypertension, where blood pressure, systolic high pressure between 130 to 139, or diastolic blood pressure 80 to 89 millimeter mercury, management should be start with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Now, everybody got to know about the COVID-19 pandemic, where acute respiratory distress syndrome is found to be fatal, where a recent study which appears in the Journal of American College of Cardiology reports that metoprolol, it's a beta blocker, can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. So it is a latest journal published in 2021 September. It is the American College of Cardiology journal. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter mercury range substantially reduced CV cardiovascular adverse events in the STEP randomized trial, affirming the SPRINT findings for an older Chinese population. Among some 8,500 patients ages between 60 to 80 in China, the intensive target trimmed 26% of the composite CV risks. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold to 130 to 150 millimeter mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office blood pressure measurement, but also on out-of-office measurements like ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime blood pressure measurement were associated with greater risks of mortality and a composite of CV outcome. Thus, They may be considered as the most relevant measurement for estimating cardiovascular risk. For every systolic 20 and diastolic 10 millimeter mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Then another advancement, most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dosed combination of ACE inhibitors like enalapril, lisinopril, or angiotensin receptor blockers, plus calcium channel blockers or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. It is another recent announcement in hypertension. It's got to know from the reason is a detection of known carcinogen, namely NDMA and nitrous dimethylamine, which can be found in irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The last but not the least, the HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening therapy, antihypertensive therapy, exerts a favorable CV risk reduction. The largest study, 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced a primary CV outcome. So an ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. That's all. Thank you so much.